Today we'd like to talk about the challenges of positioning and exposure of obese patients. Supersizing Radiology, The Obesity Connection by Mark Struthers. A recent study from Harvard Medical School states that as the morbidly obese increase, so do the number of suboptimal studies. We are going to explore today how to improve those studies. The majority of these studies are in morbidly obese patients with a body mass index of 40 and above, which would be at least 100 pounds overweight. It takes a radiographer or a sonographer that understands the equipment and imaging basics to image and get a diagnostic result with an obese patient. An experienced radiographer with a knowledge of both body habitus and positioning techniques combined with basic X-ray physics can produce a good image on most patients. So let's begin our journey by welcoming the extra-large patient to the imaging suite. It is here that the radiographer puts their skills to the test. And one of the major challenges is radiographing the morbidly obese patient. The challenges facing radiology departments include difficulties in transporting patients to the department and the inability to accommodate large patients on currently designed imaging equipment and difficulties in positioning of large patients. In addition, exposure techniques are critical due to the large amount of scatter that occurs when irradiating a large patient. For physicians, radiographers, and the patients, the main concern in radiographing the morbidly obese seems to be the amount of radiation required to get an image. This may have been a major concern in the film screen era, but it has lessened considerably utilizing digital imaging. A recent study on radiation exposure on obese people concluded that the overall risk of cancer caused by the extra radiation was approximately 153% of that of normal weight people undergoing X-ray. With the improved dynamic range and low exposures that digital acquisition of images can produce, this is no longer a worry or a risk as much as it was in the film screen era. Let's review some of the factors that a radiographer needs to consider prior to making an exposure. The factors standardized in a technique are the anatomic part being examined, the grid ratio, the kilovoltage peak, the milliamperage, central ray location, part thickness and measuring point, type of image receptor, position or projection, the focal spot size, and finally the source to image distance. Let's address radiophobia, which is a fear of ionizing radiation. It is common among healthcare professionals, patients, and the general public. Most healthcare professionals do not understand radiation exposure and radiation safety. The exception would be the radiologist, the radiation physicist, and the radiographer. Part of this misconception or lack of knowledge comes because there are two types of radiation being used in medical healthcare today. There is low dose, which is used in radiology, and there is high dose that is used in radiation therapy. The high doses used in radiation therapy are in MeV and create significant damage to the tissues, which is the purpose of radiation therapy, to kill tumor tissue. The probability of damage being done to the patient and tissue with low-dose radiology used in diagnostic imaging is almost non-existent. The American Nuclear Society concurs with the Health Physics Society position that there is substantial and convincing scientific evidence for health risks at high dose, but below 10 RIMS or 1,000 sieverts, which includes occupational and environmental exposures, risks of health effects are either too small to be observed or non-existent. This chart indicates that once you hit 1 sievert or an exposure above 10 rem, there is a possibility of cancer and damage to the tissues. All occupationally exposed radiation workers can receive a maximum of 5 rem per year, which is equal to 50 millisieverts. 50 millisieverts, or 5 rem, is 1/2 the 10 rem dose, which is the minimum amount of dose you'd have to receive in exposure to have risk of cancer. And patients can only receive 1/10 of that dose. So what is the probability of a patient getting cancer from exposure to X-ray? This graphic represents the idea that you can get exposures from different types of imaging modalities, but they will all be in millisieverts of exposure. For people who receive low doses of radiation, the risk of cancer from radiation exposure is so small that it cannot be separated from exposure to chemicals, genetics, smoking, or diet. For low-dose X-ray patients, there is a minimal risk for receiving enough radiation to cause cancer. Most researchers agree that there is no such thing as a dose of ionizing radiation that is so low that it will not have some effect on our body, such as damaging cells. Usually the damage is small enough that one dose does not lead to any health problems. It is likely that the increased risk of cancer from low-dose radiation is so low that studies in general population cannot detect it. Typical radiation exposures for patient: chest X-ray, 0.1 millisievert; extremity, 0.001 millisievert; and spine X-ray, 1.5 millisieverts. These exposures range from a comparable 3 hours of natural background radiation exposure to about 6 months of natural background radiation exposure. Now that we've eliminated the radiophobia for low-dose radiation, let's take a look at the actual increases in radiation for the morbidly obese. To begin with, the background: 50% of all patients seen in an emergency department required some type of imaging. If 1% of the American population is super obese, then we really have a very small population to worry about. This is a small population that we're going to explore today for acquiring images. Most of these patients will get diagnostic images from plain radiography because the use of CT and MR is limited due to the size of the opening of the gantry in which the patient must fit. 25% of all USA emergency departments are unable to CT patients above 350 pounds, and 66% of all USA departments are unable to do MRI patients above 350 pounds, while 90% of all U.S. emergency departments are unable to perform CT or MR on patients above 450 pounds. So now we're going to take a look at the factors in providing plain radiographic diagnostic images for obese patients, morbidly obese patients. Have no fear, yes, you can image the obese patient. Here we see an example of a vet using a CR system, computed radiography system, to do x-rays on an elephant. And did you know that 80 kVp would penetrate an elephant? Not only is the correct exposure critical, but positioning is essential for doing the morbidly obese or large patient. The attenuation characteristics of human tissue, which begin to dominate when the patient reaches 250 pounds or more, is scatter radiation. The sheer difficulty of moving and transporting patients results in staff injuries and suboptimal images. So these are probably the main issues in imaging the extra-large patient. Morbidly obese patients are sometimes very difficult to position, and typically an imaging staff is not aware that a patient is obese and may need special equipment until they arrive into the department. Preparing for the patient's specific challenges and needs may take extra time and disrupting the imaging schedule. Radiology departments often must address several issues when accommodating the morbidly obese patient. What is the best technique to image a obese patient for a given indication? That includes which modality to use and what techniques and positioning to use. Another consideration is how should the obese patient be scheduled and transported to the radiology department? And finally, how will the patient fit on the image equipment that is available, and how should equipment be modified to optimize image quality for these obese patients? Today's world of digital radiography has completely simplified the process of capturing images for diagnostic radiology. In fact, the most modern DR systems equipped now have more sensitive panels and integrated technical charts to divide most anatomical options into two categories: cranial and extremity, and all others. Then, as the patient size increases, you only need to increase technique. DR panels have evolved over the past 15 years with better scintillators, more efficient electronics, and more advanced image processing. This has led to exposure techniques that can significantly reduce the mass required in making an exposure. Unfortunately, this evolution is not the same for KVP, which is the other part of the exposure technique. For KVP is penetration. The image receptor intercepts X-ray beam after it passes through the patient's body. It produces an image in a digital format, that is, a matrix of pixels, each with a numerical value that are aligned in either rows or columns. The numerical value is married to a lookup table specific for the anatomy being displayed. The lookup table requires a certain amount of information, and to get that type of information, we have to increase the total amount of signal for the obese patient, or mass. Therefore, we do not want to use the AEC, but substitute our own technique so that we do get enough signal to create an image. If we don't have enough mass, the lower dose gives us a noisy image. Noisy images or quantum model is caused by the lack of signal, and as we increase signal, we decrease the noise and we can read the image because we have enough data or information recorded. As a radiographer, we know that our exposure index lets us know how much dose that we actually got and is it sufficient for the image that we want to create, or is it an overexposure or an underexposure? The radiation that reaches the detector is called remnant radiation, and it creates the latent image. The contrast of this image is produced by how an object attenuates the X-ray beam. Attenuation is a reflection of the thickness of the area captured and the types of tissue in the area captured. Image contrast is generated by the difference between the absorbed photons and the transmitted photons that are measured on the detector. If the area acquired comes from a thinner or smaller patient as opposed to a larger or thicker patient, we'll get less scatter radiation. If the patient is larger or obese, we'll get more scatter radiation, which we do not want because it puts sort of a fog over the entire contrast of the image. Scatter radiation reduces contrast. So let's take a look at the attenuation of the beam and how thickness influences the contrast because of scatter radiation. To improve the quality of the image, we need to either reduce or subtract the scatter radiation from the image. The output is affected by the intensity in and the intensity out of the attenuation, which is made up of photoelectric effect and Compton scatter. The photoelectric effect is a direct correlation to the absorption of the tissues. The rest of the image is comprised of Compton scatter, which we do not want to see. Remember, the thinner habitus means less scatter. If we must increase our KVP in order to get sufficient penetration through the patient, we are going to have a greater amount of scatter and a lesser amount of photoelectric interaction. The radiographer selects MA, time and kVp to make an exposure. There is a relationship between the mass and the kVp, or called the 50-15 rule, which if we increase the kVp by 15%, it would be the same as doubling the mass, or vice versa, if we decrease, it'd be the same as cutting the mass in half. As kVp increases, contrast decreases. Radiographers are heavily reliant on visual and tactile senses to locate the position of anatomical structures for diagnostic imaging and determine radiation exposure through a delicate consideration of dose. This means we have to look at image quality and anatomical attenuation for our patient. For the spine and abdomen area, we often have to palpate the top of the iliac crest, but if you can't feel it or find it, you have a problem. An old trick would be to use the height of the elbow, but the height of the elbow is a problem because as we get fatter, our arms go out wider. So you have to be visually adept when making judgments as to location of non-palpable body parts. It may be possible to either compress the adipose tissue or change the way we actually position the patient so the adipose tissue falls like in a vertical or standing position to allow us to get through a thinner piece of anatomy. This is totally dependent upon the patient's cooperation and mobility. For example, if we do a supine chest on an obese person, the diaphragm pushes the heart out and widens the cardiac silhouette. It also has the fat over the bottom area of the diaphragm. And because of the SID, we have magnification, and we also have the inability of the patient to take in as deep a breath to expand the lungs because they're supine. The advantage of digital acquisition of information for X-ray today is much different than film screen acquisition of the past. With digital, we can optimize image quality by manipulating the digital data to improve the visualization of anatomy and pathology after exposure to the patient. Let's take a look and see if we can improve the exposure of this original image. In digital, we can manipulate the dynamic range of the image by using contrast and brightness adjustments. Here we've increased the contrast by 40%. We again then take our original image and just increase the brightness, and here we've increased the brightness by 10%. By manipulating the contrast and brightness, we can get a better diagnostic image than the original. Prior to taking the image, we can also utilize an anti-scatter grid. The grid will eliminate scatter radiation from the image. This is the same for both digital and film screen X-ray. Prior to making an exposure and evaluating positioning, we need to take a look at the patient's body habitus with the relationship to the internal organs that we're trying to display. Remember, the patient's body habitus does have an impact on the value of interest area and where it is on that particular patient's body. For an example, let's take a look at an average-sized patient and an obese patient. Do you see a difference in the quality of the images that can be produced and where you might adjust your positioning? Beyond the patient, you also have to look at your equipment, especially the type of receptor that you're utilizing to capture the image. A computed radiography imaging plate differs from a direct digital radiography receptor. And the DDR, or direct digital radiography image receptor, has two basic types of acquisition, direct and indirect, which affect the light spread of the image. It is vital that you understand your equipment as well as body habitus of the patient when making an exposure. Another factor to reduce scatter is the use of collimation. Your equipment is collimation dependent. The greater the collimation to the area of interest, the less the scatter. The more open the collimation, the greater the scatter. As you adjust your kilovoltage in choosing technique, you must know the difference between KeV and KVP. KeV is the average energy of penetration of the beam, and KVP is kilovolts peak. It is the maximum. It cannot penetrate any more than that peak area. Usually the KeV is about half or a little more than half of the KVP. So what we're saying is the average energy of a beam for 100 kVp would be about an average energy of 67.2 keV. Quick update on grids. There are many types of grids that are used in X-ray department. There are parallel grids, there are focus grids, there are linear grids, and there are crosshatch grids. Correct grid and grid ratio for the subject that you're trying to capture. Not just the blue grid or the yellow grid, but when you look at the back of each grid, they are firmly labeled like 8:1 focus grid or 5:1 parallel grid. Focus grids must be used in a certain SID range, and no more and no less. If used at the wrong distance, you will totally defeat the purpose of using a grid and have grid cutoff. The air gap technique changes the geometry or the scatter of the X-ray so that the scatter radiation goes outside the receptor somewhat. So the air gap, like the grid, will reduce some of the scatter, but not all. So let's see what happens and how we supersize our radiology department. We'll look at plain radiography, CT, MRI, and ultrasound. Upsizing the CT scanner would mean that we'd have to increase the table weight support and maybe increase the aperture diameter for the patient to go through. The same with MRI, table support, and diameter of the MRI. We now have what's called wide bore MRIs. When we look at ultrasound or sonography, lowering the frequency for the ultrasound transducers will give us better penetration. And of course, for plain radiography, we need to upgrade the table weight support and redesign the X-ray and fluoro table to allow more distance for girth. What are some of the challenges for imaging bariatric patients, no matter what type of modality? The first would be radiation attenuation. We'd have a signal that was decreased, so we'd end up with low contrast and more noise. Longer exposure times, which means more radiation exposure, and because of the long times, artifacts due to motion. And there are no dose guidelines for the obese. Radiological services and equipment are not yet adapted to these patients. The accuracy of current MR, CT, and ultrasound is hindered by subcutaneous and intra-abdominal fat. And these modalities are crucial in diagnosing pathologies associated with obesity. 10% of the nation's emergency departments have a CT or MRI that will image a patient exceeding 490 pounds. In the bariatric centers of excellence, only 21% could accommodate the largest patients. This means in a busy ER, which sees about 300 patients per day, one of those patients would be so big they could not be imaged, and 3 patients would be severely restricted or very challenging for imaging. Of all the diagnostic imaging modalities, CT is usually the best answer for imaging the obese patient. CT challenges include the weight and size of the patient, positioning the patient, penetration, radiation, and IV access for contrast media. Obviously, weight is the gatekeeper. A patient can either get on the table or they cannot, and if the table strength can hold them, it may not be able to move. Weight also determines if the table can be moved up or down. The table might support the weight if it is moved to the level of the gantry aperture before the patient is loaded, but once they're in, how do you move them up and down? Theoretically, tables are tested to 4 times the weight limit, but who can take that chance if it negates the warranty or the table breaks and it costs $20,000 to fix it? GE boasts a table limit of 650 pounds, while Siemens advertises a table for 615. Philips also states they have a table that will hold 650 pounds. Toshiba has still to reach 600. They are at 450 pounds. Also, everybody's built different. If you take a look at the aperture size or the opening size, what you have to look at is some people have different body habituses, and size tells us something about the shape of the patient. They may be a pear or an apple, or in other words, where is the weight located and can he or she fit in the gantry? Also, we need to look at the relationship of the table to the gantry opening and where the patient lies. The CT scanner manufacturers tell us the gantry is 70 centimeters in diameter, but when the table is moved into the gantry, 18 to 20 centimeters is lost due to the table size. The FOV, or field of view, is also limited. The reconstructed field of view is 50 cms in most scanners, providing a balance between spatial resolution and coverage of the area of interest. If part of the patient volume is outside of the reconstructed field of view, an out-of-field artifact is produced. The scanner cannot tell what is attenuating the beam, and it produces a too bright edge around the image. Again, we have to worry about the amount of signal or mass that we're using. We can get quantum model or photon starvation as a result of too few X-ray photons reaching the detector. This increases image noise and degrades image quality. The solution to photon starvation is to increase the number of photons, which gets more X-ray to the detector. This means increasing the MA, which increases the radiation dose. The obese patient receives 3 to 4 times more dose than the average patient. Other techniques that may be used in CT would be to increase the MA toward maximum or decrease pitch, and that is the ratio of table movement per 360-degree rotation in a single slice. Another way to increase signal is to increase rotation time or increase reconstruction slice thickness. Use a soft reconstruction algorithm or use a dual source CT. Reconstruction of the obese should be done in thicker slices. If the 50 cm field of view slice thickness should be 5 to 10 millimeters, the radiologist will just have to live with partial volume averaging artifacts that they see. To increase signal to noise ratios and improve quality, the kV must be increased. Increasing from 80 to 140 kVp will produce significantly better imaging. Also, you need to put in a manual technique. It is not recommended to use the automatic exposure control for the obese patient. This will be a noisy image, but noise acceptance must be dependent upon visualization of the indicated exam. It is felt more noise would be acceptable for kidney stones than for the amount of radiation that could cause carcinoma. The main limit for MRI is the bore diameter of the magnet and the table weight limit. Today, we have much greater diameter bores. In fact, we have what's called a wide bore magnet, which has a much larger aperture than what we used to have. The wide bore was developed not only for the obese patient, but for those patients that have claustrophobia. With a smaller bore magnet, it is easy to get claustrophobic inside the MRI scanner. With the smaller bore magnet, there may be contact with the sides of the magnet, which can produce eddy currents that degrade the images. And there may be a danger of a burn if the skin is not protected by at least a cloth. The burns occur because we've actually completed a circuit using our body. So the electricity is going through our body. Remember, we're using electromagnetic radiation and we're using the radio frequency signals. With today's larger population and the popularity of bariatric surgery, it will keep a steady influx of obese patients coming into our facilities. They will need our imaging procedures and our expertise. We must be prepared. Thanks for your time and for your interest. I hope that you have gotten something out of this presentation. And remember, you can do it. You can beat the challenge of the obese patient.